But Raina, I wonder if you could comment a little bit on what the patient brings to the table. How do you incorporate patient preference into this decision process in terms of goals of care? Because I think Niraj mentioned, complete responses is a really important endpoint and a differentiating point from the single agent TKIs. But is that important in every patient, in every setting? How do you factor in kind of comorbidities and other factors for the patient? What are your thoughts on sort of rounding out this whole discussion with patients?
Yeah, I mean, I think that's a key point. So I think with the advent of the IO-IO and IO-TKI combinations, our endpoints are changing and the things that matter are changing. So whereas before it was largely PFS, and that's really what we looked at, and maybe you can get a little bit of bang for your buck with OS, but it was largely, PFS that led to approvals of our VEGF targeting agents. But now we look at a lot of things. Now, in addition to complete response and durability of response, we're looking at, well, what's the primary PD rate? We're looking at what's the toxicity profile of this regimen? What's the risk of immune-related AEs? What's the risk of use of high-dose steroids? Do you have the multidisciplinary team to be able to manage that IO tox? What's the tox with, IO-TKI, chronicity of TKI therapy, toxicity? So I think all of that gets factored in when deciding what is the most appropriate regimen. A patient's age, fitness level, their goals for therapy matter, clearly, so you may have a favorable risk patient who is young and healthy, and though they're favorable risk, you still may be swayed to use an IO-IO combination for that individual. You may have a poor risk patient that maybe is older, doesn't want to come in and get IV treatment, lives far away from the center, has other comorbidities that you're going to say, we're just going to do cabozantinib for you alone from Cabo Sun data, So I think, it's important to understand what the data shows us, but there's a lot of gray and art in how we practice in those day-to-day engagements with the patient. And you need to understand what you do know and know where the gaps are and, try to, basically come to a therapeutic decision with the patient, interpreting the data and sort of what the patient brings to the table. So I think our endpoints are changing. The patient populations in all of these trials, though, all we want to do is sit there and pin them head to head, one against each other, and nitpick at every little thing. I'm so guilty of that. They're all different. They were accrued at different times in different parts of the world with different patient populations. And so I think understanding that is important as you apply in the clinical setting.
That's fantastic. And I agree with you, Rand. And I think this is sort of the art of what we do, right? I mean, there's sort of what we might think is the best choice, and then there's the, what's the really realistic choice that patient can do and tolerate and benefit from, and still benefit from. And it's great that we have this spectrum of trials that span across here. And Monty, what are your thoughts on sort of the applicability of this clinical trial data? Because these clinical trial patients, if you look at them, they don't. A lot of our patients in clinic wouldn't necessarily qualify for this trial or that trial based on some eligibility criteria and other factors. I mean, how well does the Checkmate 214 data translate into your, off-study patient population?
Yeah, it's tough. I mean, the one thing that, we've become accustomed to doing now in the clinic is really, screening intensively, right, for any autoimmune conditions. That really wasn't part of my initial, dogma in clinical practice. But I struggle with those patients as one example, right? I mean, it's very challenging for me to know what to do with somebody with mild rheumatoid arthritis. Could I potentially challenge them with Nivo/Ipi? I'm tending to really favor either TKI monotherapy or TKI plus IO in those cohorts. Hard to know what to do with poor performance status patients that might not meet the mark for many of these studies. There, I actually do find myself leaning on Nivo/Ipi to a greater extent, perhaps. But I have to agree with what you said, Dan. I mean, I think it's very challenging to know how to extrapolate clinical trial data to some of these unique patients.
Yeah. I mean, there have been some studies to look at this, right? Some of our non-clear cell populations, some of our brain met populations, some of the poor performance status populations. They're small, single arm, kind of analyses, but at least they're giving us a glimmer of hope that, yeah, there are some patient populations not represented in the original 214 study that could still tolerate and potentially benefit, from these regimens. But it's not going to be the same result, that 11% CR rate, that really good, duration of response and other things. The number of patients that get through all 4 doses of ipilimumab may be lower. But do you still see benefit in those populations?
Yeah, I'll try to take a stab at that. I definitely think that, there are occasions in which I've been pleasantly surprised by how, the non-protocol patient in my practice responds beautifully to a challenge with systemic treatment, whether it's Nivo-Ipi or Cabo, frontline by a Cabo son. So I definitely can cite multiple examples where I've been pleasantly surprised by responses.
And I agree with you. I think this is one of the key things is that, if you treat enough kidney cancer patients, you're going to get these exceptional responders. And they're not always in the patients that you would predict that they would be in. And I think that's one of the things that's really important out there, is not kind of give up on these regimens because of 1 or 2 negative experiences. That there will be those, but if you treat enough patients, you will see these really positive results. And they're life-altering results when you see them in this frontline setting, especially.